Hey, it's the beginning of a week, and I'm headed into endometriosis surgery. Come on and join me. No, really. Come on.
So as I begin, the uterus is being elevated up, and we look down into the pelvis and immediately see endometriosis lesions. I'm moving the left ovary out of the way. And on the left side of the screen, that's a very classic endometriosis in the deep central pelvis. We call it the cul-de-sac. If you look off to the right here, adjacent to and beneath the right ovary, we see more endometriosis lesions as well. These are the more classic, sometimes called powder burn lesions. They're dark, and relatively easily seen. There are many other appearances, you might say, of endometriosis. This is the one that's probably the most commonly seen. Here I'm beginning to excise this small endometriosis lesion. To excise is to remove or to cut out, simply stated. It's not burning, it's not fulgurating, it's not ablating, it's not any word that means anything other than to completely remove or excise. That's critical for the successful long-term treatment of endometriosis, both for pain control and for fertility preservation and enhancement. It's got to be completely removed, not burned, not scraped, but removed. So I'm excising that here three-dimensionally because very often there's more endometriosis beneath the surface than meets the eye. But you'll see this lesion is completely removed. I'm doing the same thing on these neighboring lesions that are in this area that we call the cul-de-sac. This is actually immediately beneath the cervix, and I'm going to completely excise those other lesions as well. I'm using micro shears here with the Da Vinci robot. They have the ability to have current pass through them that I control with a foot pedal. And that's why you see sometimes smoke. Electricity can be passing between the two shears, and that causes some coagulation of micro blood vessels at the same time that they're being used as a regular cutting device, as you see here. That's part of the reason you see minimal, if any, blood. And that's also part of our one of our many important steps at preventing adhesions or scarring. This, however, is probably the most important tool in our bag when it comes to preserving and enhancing fertility and preventing scarring. This is called pelvioplasty. It's where we repair the pelvis after having excised all of the endometriosis. So here I'm sewing the I'm sewing the peritoneum back together again. This suture is a little larger in diameter than a human hair. It's absorbable, that means it will eventually dissolve, but I don't want that open area, that raw tissue exposed during the typical 2 weeks or so that it would take for this to heal, because the tubes or the ovaries or other structures could become adhered or stuck to that, creating scar tissue formation and other problems. Pelvioplasty is absolutely critical in the successful treatment of endometriosis via excision. So you can see here as I finish up, I'd like to think that it looks like we were never there. We've left no footprints behind. We've removed all of the endometriosis, and I've covered any raw edges by the pelvioplasty procedure. And not only have I made her pelvis better by removing the disease, but I've prevented scar tissue formation and adhesion formation. So this is pelvioplasty after complete excision of endometriosis. I hope you've enjoyed this. Thanks for joining me for a few minutes in surgery. I'll be back soon with more advanced robotic excisional endometriosis surgery. I'm Dr. Chris Stroud.